think primarily because it is a combination of an initiative in which we initially started at the bedside saying, this is all about us being just practicing best practice. And we started realizing as we got into that we were failing, and we subsequently, as we looked at the problems that were developing, we realized that the only way we could solve this was by using some of the technology we already had, using it differently. And then subsequently started looking at some of our telehealth capabilities and realizing that if we integrated all these things, we would succeed where we had previously failed. So for the non-clinical people out there, we're going to talk about sepsis. Sepsis is an infection that spreads out of the localized area into the body. And severe sepsis is when things start getting worse. So just very quickly, severe sepsis is very common. This compares it to some of the other diseases that get a lot more press, and you will see that severe sepsis is as common or more common than all of those things across the country. Severe sepsis is just as deadly, killing as many people each year as acute myocardial infarction, and more people with breast cancer or AIDS. So it's a very common problem. And in terms of how effective you can be if you jump on it, this is the number needed to treat. If you address severe sepsis with what we call early goal-directed therapy, you need to treat about 6 people in order to save 1 life. In comparison, internal defibrillators that prevent sudden death, or treatment for acute coronary syndromes, acute myocardial infarctions, have to treat 15 to 20 or 25 to 35 people before they save 1 person. So the message is that severe sepsis is a very common problem across this country. It kills many people, and if we just treated it appropriately, we could save many lives. But the problem is, across the country, although we know what to do, taking what you know how to do and actually implementing it and operationalizing it 24/7, 365 days a year in every nook and cranny of every hospital is a real challenge. For a layperson, sepsis, if you have an infection that doesn't stay controlled and spreads to the rest of your body, that's sepsis. And then as it progresses and starts causing your organs to fail, that's severe sepsis. And when you go over the cliff and start to die in shock, that's septic shock. So it's a spectrum of out-of-control infection. So we decided to look at how well we did, especially since we had started a big sepsis initiative at our place in St. Louis. And we, together with Booz Allen, we did some mining of our medical records, not just in our St. Louis hospital, but also in our Oklahoma City hospital, and then in one of our smaller hospitals. And we found out we weren't doing very well at all. In fact, we were doing horribly. You can see the numbers here. Now, part of this is altered by the fact that we were looking at big bundles. In clinical care these days, we talk about bundles, and it may put 10 or 12 elements together of things you should do. And you only get full credit if you do everything in the bundle. So even if there were 10 elements and 90% of the time you did all 10 elements, you get a 0 because you only succeed when you get the whole bundle together all at once. But we were doing a pretty lousy job. And actually, if you look at a number of published series across the country, everyone, if they look at how compliant they are with sepsis bundles, they don't come out very successful. Now, despite the fact we weren't compliant with the bundles, our mortality data was actually about what people published. Our severe sepsis to septic shock mortality was anywhere from 24 to 50%, which is what most people in large studies would publish. So we weren't worse than everyone else. We weren't better than anyone else either. And these type of cases also, because money is always important, result in significant money lost to the hospitals, significant length of stays, and significant 30-day readmission rates, all of which you've heard are important in, today and in our upcoming healthcare model. So we had tried two initial projects, one in Oklahoma City and one in St. Louis. The one in Oklahoma City was a side project from our tele-ICU. Now, let me just talk about tele-ICU for a minute for those of you who don't know. We have a central core here in St. Louis. From that core, we are monitoring 450 ICU beds across 4 states. We see everything that they see at the bedside. We have all their real-time monitors. We have their electronic record. We have their PAC system to look at their x-rays. We have all their labs. We have two-way video in every room so we can zoom in and examine patients so we can write orders on these patients. So we felt like we had a pretty good lock on the Oklahoma City ICU. But when we tried to do a sepsis initiative there, what we found out was that it wasn't working because the doctors didn't buy into it. And that means the doctors didn't like the loss of autonomy, they didn't like the interference with their prerogative to do what they wanted to do. Teamwork wasn't working well. We knew we didn't have any champions on the ground. They didn't, even though we explained the data to them, they weren't convinced there was a real problem. And perhaps most importantly, as we spread out of the hospital onto the medical floors, we didn't have the same intensity of monitoring on the floors that we had in the ICUs. And more importantly, we didn't have the same intensity of data collection on patients on the floors that we had in the ICUs. If someone's out on the floor and you're only collecting information every 12 hours, well, they can go from being not too sick to a little sick to really sick to crashing in that 12-hour period, and there's no new information coming in on them necessarily. So that was a real issue. In St. Louis, where we had focused on the bedside teams picking up the sick people sooner, we realized that the same issue of having champions on the ground was an important issue. We also realized that there had to be very granular, we had to have a committee that was looking at the activities on a weekly basis to do continuous quality improvement, to identify what we were doing right and what we were doing wrong. We identified that getting antibiotics into somebody quickly was a chore. We could write orders quickly, but getting that translated into getting antibiotics actually into the person quickly was a process thing that had to be correct. And then we identified the same issue of patients on the floors with the lack of constant data to analyze to see, in fact, whether people were deteriorating or not. So this is our big picture. We discovered, first and foremost, this was not about just making people follow best bundle practices. It was about a hospital-wide, multi-departmental issue. It wasn't just an ICU issue, it wasn't just a floor issue, it was an emergency room issue. You had to involve lots of different departments with lots of different personnel, all working for the goal of taking care of sepsis and not necessarily working for the goal to make their own little departments run well. So it was a lot about cultural change. And then we needed to leverage the technology we had in order to identify these sick patients sooner. Because the sooner you identify a septic patient and start acting on them, the better off they do. When they crash and get to the ICU, which is where we tended to focus our tele-ICU and most of our technology, that was after the fact. You'd like to get them before they have deteriorated enough to get to the ICU. So that was a big challenge that we're going to leverage our technology for. We clearly had to implement best practices. We had to do things consistently. Non-variation is a big issue in healthcare. That's always a challenge. And then we had to monitor all of these patients consistently. So we did a couple of things. The first thing we said was, we have this huge EMR, and we have Epic at all our Mercy facilities. So we said, everyone in the hospital is in Epic. So we built we call it EWIS, our Early Warning Information System. We built this rules engine that sits on top of Epic, or actually takes data that comes out of the interface that needs vital sign data, lab data, and all the information, and puts it into Epic. We built this system on top of Epic and wrote rules looking for patients at risk for sepsis. So we now, in St. Louis, for instance, we're an 870-bed hospital. We looked at every patient that was registered in Epic, including our emergency room. And this rules engine immediately was sitting in the background looking and alarming when it saw someone who was at risk for sepsis or had early sepsis. And on a given day in St. Louis, that ends up out of 975 patients plus emergency room people, it ends up being about 110 patients a day, fire in EWIS. So we've immediately defined a subset of patients using technology to just run rules engines that highlight 110 of our sickest patients. We then take those patients and we use a sepsis alert that's part of our tele-ICU. Now, this sepsis alert is a proprietary bit of information that analyzes all the patients in our ICUs, but doesn't analyze the patients in the rest of the hospital. But we can actually create a virtual unit that we put all these EWIS-fired patients into, and when that fires, we now have a smaller subset of patients that have been electronically surveyed and warn us when it looks like they have deteriorating sepsis. At that point, our EICU is doing this. At that point, our tele-ICU jumps on that person, looks at them in more detail, calls an alert for our bedside rapid response team to go and see that patient and immediately start resuscitating them. And then we built in some automatic things like they automatically go to the ICU. All this without calling the individual physicians or getting into individual variation. The whole system just moves down and triages those patients to where they best go. So in addition to that, we obviously did the typical things of best practice. We have protocols, order sets, care paths to ensure consistency. That's all after the patients have been identified. So again, this outlines, again, here's the big picture. The whole Mercy Hospital is white. The early warning system defines a subset of patients who are septic, puts them in our virtual sepsis unit, where there's an algorithm looking at them. As soon as they deteriorate, it fires. Our sepsis nurse in our tele-ICU calls the bedside and says, this patient fired, we need to call the rapid response team. They then go and look at that patient and according to a set of protocols and algorithms, automatically treat that patient and start the resuscitation process. And only after all that is in place does the individual doctor get a phone call telling them what's been going on.
So this is about getting the medication to the patient in time.
It's not only getting medication quickly, but it's a time-intensive therapy. So if these patients are recognized and jumped on with a number of therapeutic endeavors within a half an hour, they do much better than if they are sort of recognized, thought about, are they really sick, and all that happens about 3 or 4 hours later, their outcomes are very different. So it's about early diagnosis, assessment, and rapid treatment. In a patient that everyone's saying, are we sure they're sick or not? And when you are sure, it's too late. That's the